Hello? Anyone there? Hello, New York. Is that you? Hello, it's so exciting. It's me, Declan Murphy, beaming in from Melbourne. Can you believe it? It's fantastic. Dr. Tuari said, can you come to New York virtually? I said, hologram me there, etc. I'm so excited. Thank you for the invitation and thank you for allowing me to speak to this great conference. Sorry I can't be there in person, but hey, this is the next best thing and it's a bit of fun. And if I can't join you in person for a beer tonight, I'm sure you'll all be having a drink. I'll be toasting your good health from right here in sunny Melbourne at the height of summer. Thank you very much, Dr. Tuari, for asking me to address this strange topic, this very strange question. Should we do a radical prostatectomy without a prostate biopsy, without proof of cancer? Well, I suppose like all things in life, we could do it. We do stupid things all the time. It doesn't mean we should do it. But that's exactly the question I'm going to address in the next few minutes, and I hope you enjoy. So for me, there are two reasons why we're even asking this question about doing surgery without a prostate biopsy. The first is the prostate biopsy. It's not very comfortable, looking into this audience, it's, a lot of men out there, a lot of men in their 50s and 60s, maybe some in the 70s. In other words, a target audience for prostate cancer. Indeed, I'm sure some of you have had a prostate biopsy. Probably a transrectal prostate biopsy through the poo into the prostate. It's a disastrous thing. Some people are very badly injured by this. Some people even die. And that's what this paper at EAU this year was about. Deaths in Norway. 20 deaths per year, they said, based on registries. And when they switched to transperineal biopsy, 0 deaths per year. But the point is, prostate biopsy can be uncomfortable. It can be even dangerous. So that's the first reason we're asking a question about whether we still need to do it. The second reason we're asking the question is about imaging. It's about the allure of PSMA PET CT, this gorgeous molecular imaging that we've all got really used to in recent years. We've got used to seeing not just the lymph nodes and the metastases, but the prostate as well. The prostate lights up in these patients. Is that enough? Well, that's what we're going to consider. And I hope you open your minds as I tackle this quite contentious topic, because I know some of you in the audience are already saying, this is crazy, we're not doing that. But consider for a minute what we thought about PSMA PET CT when we first got access 10 years ago. This is one of my first patients 9 years ago, 2014. And we couldn't believe it when we saw the sharp tumor to background ratio. We could see the prostate, we could see the lymph nodes, we could see the bones, all in one beautiful whole body scan. So immediately this was a challenge to what we were used to conventional imaging. We went on and did a prospective multi-center randomized trial comparing PET imaging with conventional imaging for staging patients. And we proved that yes, PSMA PET CT is a lot more accurate. We find the stuff that you don't see, but we also prove that the equivocal lesions are positive or negative. So accuracy is the key endpoint that we proved in the ProPSMA trial. And as we were doing that trial, which was a staging trial, we began to notice that the prostate itself was telling us a lot about what was going on. Here you see a typical example of a 61-year-old with a raised PSA. He's got a very abnormal lesion we can see on his MRI. He's had a biopsy showing grade group 3 cancer throughout that lesion. And here's his PSMA PET CT. It's all telling the same story, a very avid lesion, concordant with the MR and the prostate biopsies. So in the middle, the question is, did we need to do the biopsy? And this is the paper that has triggered the madness, the controversy. This is a retrospective series published in European Urology, the world's highest ranked urology journal, early last year. It was a series of patients from Munich in Germany who, quote, expressed the explicit wish to avoid a biopsy and go straight to surgery. They were refusing a biopsy. So over a period from 2015 to 2021, they accumulated 25 of these patients in Munich. And the question was, well, did it turn out that they all had significant cancer? Here's one of the very nice examples they show in the series where everything is matching up. And yes, the answer was, at the end of the day, all of these men had clinically significant cancer. But I suppose what if one didn't is the question we're all asking ourselves. And certainly a retrospective series is not enough to change practice. And boy, did this cause some controversy. I recall when this tweet came out from European Urology in December 2021, just before the paper came out. And here we have Hash Ahmed saying there are significant ethical concerns about this. Another author saying that he was surprised it's been published, no ethics, etc. This author is asking, what if the diagnosis was wrong even once? Wouldn't that be a terrible penalty to pay? Is it even legal? We're asking the question. So yeah, and the tweets went on and on and on, and you can read right through them, but the message is the same. People are finding this to be a very disturbing proposal that we do surgery without a biopsy, and especially when based on a retrospective series. So I want to talk to you about two different sets of data that perhaps fuel that fire and give us some rationale to at least explore this topic. The first is a study we ran, a prospective study called the Primary Study, published in European Urology. This is men who were suspected of having prostate cancer, so were scheduled to undergo a biopsy. They'd also all undergone an MRI because that's standard of care in Australia. And what we did was, before the biopsy, we did a PSMA PET CT just of the pelvis to see whether the information from that added to the MRI improved the accuracy of the biopsy. So what did we find in almost 300 men? Yeah, we showed that, I must congratulate my co-author Louise Emmett, who won a nice prize for this, best paper of the year in European Urology. But she showed that the combination of MRI and PSMA PET did improve the negative predictive value up to 91% with 97% sensitivity. So that's great. The combination of both does improve it. But of course, it's not rational, it's not sensible to say we should do both. It's hard enough to do one in many countries, hard enough just to do an MRI. But nonetheless, the combination showed real value. And we also showed that as the SUV max, and you'll hear more about that shortly, increases, it correlated with increasing aggression within the tumor. So what a biopsy might tell us, maybe a virtual type biopsy based on the PSMA PET CT. And the two key clinical messages that I want to highlight for you are, first of all, what about a de-escalation strategy? What about patients who had a negative MRI and then had a negative PSMA PET, despite perhaps the PSA being up with some clinical concern? Yeah, very many of those men could avoid a biopsy. But on the other hand, and this is our topic today, what about if both scans were positive? What if the MRI is abnormal and the PET scan is positive? And we showed two things with this. We showed that, first of all, if the SUV max is above 9 and the MRI is abnormal, all patients had clinically significant prostate cancer, all of them. And in patients who had either a normal or abnormal MRI, we showed that if the SUV max was 12 or above, all of them had clinically significant cancer. So yes, the PSMA PET combined with the MR information, especially in those with abnormal MRI, did lead to a very high prediction of clinically significant prostate cancer. And in all the discussions about this, everybody's referring back to that prospective data to say there is a rationale if you use a cut point of SUV max. The second data I want to show you is another series of patients who underwent a radical prostatectomy without a biopsy. This published just a few months ago, again from Germany, but this is a prospective ethics-approved project. And again, similar theme here, these are 50 patients who refused a prostate biopsy. So clearly, German men don't like having a prostate biopsy. They prefer to just have imaging and then have a prostatectomy. And in this series, they looked at three different groups. They looked, first of all, at a group with high-risk characteristics. They had an abnormal DRE, the PSA was high, and both the MRI and the PSMA were positive. The next group hadn't had a PSMA PET CT, a small group of patients. And the third group just had one of these characteristics, either PSA or DRE was abnormal, or one of the scans was abnormal. And what they showed was that, yes, these men all did have prostate cancer when they underwent a prostatectomy. But the ones without the PET information included patients with low-grade cancer. So this is important because their men, if we knew that beforehand, shouldn't undergo a prostatectomy in very many instances. So I think this is highlighting for us that we have to be very careful with doing this without the best information. And indeed, that's the conclusion from this paper, that radical prostatectomy without biopsy is safe in terms of the diagnosis of significant cancer, but only if the proper pre-op risk stratification is performed, and that means including both an MRI and a PSMA PET. And we would add into that with an SUV max that's at an appropriate level. But wait, the madness doesn't stop there. There's more to come. Prostatectomy without a biopsy in the PSMA-fueled era has led to some more contentious suggestions. And we're involved in some of this because we've just published a paper called Lutectomy, based on a trial where we took men with high-risk features about to undergo prostatectomy, And we gave them either 1 or 2 cycles of lutetium PSMA, radioligand therapy, which we know works in very advanced cancer. But what about in localized cancer? Can it improve outcomes? And what we did in this study was measure the dose and see was it safe. But I want to show you an example from this study. And this will explain why I'm linking it with the idea of not doing a biopsy. So PSMA here is very positive in the area where the MRI is abnormal. But this patient also has a positive lymph node. He's got a big 2-centimeter lymph node in the pelvis that you can clearly see on this scan. He underwent lutetium PSMA and received a big dose, which he tolerated very well. We repeat the scan 6 weeks later, just prior to surgery, and look, the lymph node has completely disappeared. So that patient is now saying to us, well, do I even need a prostatectomy? What about more lutetium? Lutectomy rather than prostatectomy. So my point is that PSMA is also fueling other very disruptive ideas that it's not clear at all will be in the best interest of all patients. We did go on, of course, and convince all these patients to have surgery, even though for very many of them, their PET scans looked really, really good after some lutetium. And it was very straightforward taking out these lymph nodes, despite the fact they'd had a big dose of radiation just a few weeks prior. So what do you think, finally? You learned audience there in New York, some of whom, of course, either will have had prostate cancer or at risk of it, and think about this inside the office, but also maybe outside the office. What if this was you, a 59-year-old with a PSA of 7, a PIRADS 4 lesion in the right posterior, and you've had a PET scan. PET scan is showing an avid lesion, SUV max 17, exactly concordant with the MRI. Would you have a transrectal biopsy through the poo done by one of your colleagues just to prove that this is a significant cancer? Or would you be convinced by some of this data and be prepared to have a prostatectomy, or go on a trial at least to consider a prostatectomy? Well, this is a colleague, this is what this patient decided to do, very well informed. I'm not having a biopsy, I'm having a prostatectomy, please. And yes, he got it right. So this is a concordant lesion. We did non-nerve sparing over that lesion and got a clear margin. We did nerve sparing on the other side, despite not knowing what might have been on that other side, at least fueled by a biopsy. I'm not suggesting this is the right way forward. Indeed, I think this should only be done in prospective trials. But sometimes colleagues and clinicians and patients themselves will express a very strong wish, because in a health literate era, we must respect our patients' wishes. So my take-home message is, first of all, image-based selection for radical prostatectomy is well worth prospective evaluation, but only for very obvious cases where the MRI is abnormal and the PSMA PET CT is abnormal. And we must respect the quantitative parameters and work with our nuclear medicine colleagues. Second, well, the reason we're asking the question is because there are issues with prostate biopsy, and I think we can do better in our diagnostic pathways. We can use MR for all cases as much as we can, and don't do biopsies if MRs are normal for very many patients. And that's the first challenge, because that's still not standard of care in many countries around the world. And if you're going to do a biopsy, stick the needle through the skin, not through the poo. That's what we do in Australia. And finally, I think there is potential for real harm if not formally assessed within trials. Some patients will undergo unnecessary surgery, or we might find that the intra-op decision making is not quite as good as it would be if we knew what was on the contralateral side. That's all I have for you. Thank you once again to Dr. Tewari for the invitation. I hope you all have a wonderful evening there. I'm out of here. Thank you.